So coming to the introduction. So fulminant hepatic or acute hepatic failure is a clinical syndrome which is resulting from the massive necrosis of the hepatocytes, or there is a severe functional impairment of the hepatocytes, where the synthetic, excretory and detoxifying functions of the liver are severely impaired. This results from a rapid death of a cell or injury to the large proportion of the hepatocytes, leaving insufficient hepatic parenchymal mass to sustain a normal liver function. So hepatic encephalopathy, which is the most deadliest complication which can occur, which is an essential diagnosis, which can be diagnosed easily in the adults, but in children it is very difficult to diagnose. So coming to the definition, according to Nelson's 20th edition, so acute liver failure in children includes where there is a biochemical evidence of acute liver injury, usually less than 8 weeks duration, where the neonates may have only deranged liver functions without any overt symptoms. So less than 8 weeks of evidence of acute liver injury should be noticed in the biochemical parameters. So that is one of the component. Next one is no evidence of a known chronic liver disease either present or at the past. The next component is hepatic pace coagulopathy, defined as a prothrombin time which is more than 15 seconds, or international normalized ratio, that is INR, which is more than 1.5, that is not corrected by parenteral administration of vitamin K in the presence of a clinical hepatic encephalopathy. So this is an definitive definition of acute liver failure in children, which is according to Nelson's 20th edition. So coming to the background for this is acute hepatic failure in children is relatively a rare clinical syndrome. So mortality is almost high, about 60 to 80%. Among the different causes in the Western countries, the viral causes accounting for about 12%, drugs and chemicals for about 52%, mixed is about 10 to 22%, and miscellaneous conditions about 18%. So, but in Southeast Asian countries, hepatitis is the most predominant cause of acute liver failure, which is accounting about 50 to 70% of the causes. So coming to the epidemiology, the incidence of fulminant hepatic failure appears to be low in the United States and approximately about 2,000 cases annually. Drug-related hepatotoxicity accounting for more than 50% of acute liver failure cases, including acetoaminophene toxicity, which is the major deadliest complication can be seen when there is an overdose, and idiosyncratic drug reactions accounting for about 12%. So nearly 15% of the cases remain interdeterminate etiology. So coming to the etiology of acute liver failure in the different age groups, actually it is classified based on the age groups. In the pediatrics, we will be classified according to the ages. So it is classified into neonates, that is up to birth to 28 days of life. Next is infant, then will be 2 to 10 years of age and 10 to 18 years of age. So different age group present with the different conditions. So coming to the neonatal age group, the infectious causes are herpes simplex virus, adenovirus, hepatitis B virus. Next important component in the newborn period is inborn errors of metabolism, mainly galactosemia, tyrosinemia, hereditary fructose intolerance, and immune-mediated conditions like neonatal hemochromatosis. So next component will be ischemia and abnormal perfusion due to congestive heart failure in the newborn period and severe asphyxia. Drugs and toxins and other conditions like hemophagocytic syndromes. So drugs and toxins are very less in the newborn period. So coming to the infantile period, so the commonest infection is hepatitis A virus, hepatitis B virus, and herpes simplex virus. So next will be hereditary inborn error of metabolism. More important is hereditary fructose intolerance and immune-mediated conditions like autoimmune hepatitis. Whereas ischemic and abnormal perfusion will be similar, like congestive heart failure, respiratory failure. And drugs and toxins, most important drug is acetoaminophene, that is paracetamol overdose, isoniazid, and coming to the other component will be valproate. Sorry, the drugs will be acetoaminophene, isoniazid and valproate. So malignancies of the liver is a deadliest complication. So coming to 2 to 10 years of age will be similar. Infections like hepatitis A virus, B virus, and herpes simplex. Drugs will be acetaminophen, isoniazid, and valproate. Immune mediated will be autoimmune hepatitis, whereas in the infantile period is alloimmune hepatitis and hemophagocytic syndrome. Ischemia and abnormal perfusions like Budd-Chiari syndrome, heart failure, cardiac surgeries, and myocarditis. Metabolic conditions, which is one of the important condition, is the Wilson's disease, which is presenting in the children's pediatric age groups, and Reye syndrome, hemophagocytic syndrome, septicemia, heat stroke. Where 10 to 18 years of age is the similar features of the 2 to 10 years of age children. So coming to the mechanism of the hepatic injury. So the three components which are causing for the injury to the liver are immune-mediated hepatocellular injury, direct hepatocellular injuries, and ischemic hepatocellular injuries. So in the immune-mediated conditions like viral infections, drug hepatotoxicity like dihydrolysine and halothane, direct hepatocellular injuries mainly due to hepatotrophic virus family, that is hepatitis A virus, hepatitis B virus, and hepatitis C virus. Toxic or relative metabolites, that is acetaminophen, toxic metabolites of the compounds like due to metabolic diseases, and ischemic hepatocellular injury mainly due to shock status and cysts. So what are the effects? Impaired hepatocyte regeneration will occur. There will be altered parenchymal perfusion. This will resulting in endotoxemia and decreased hepatoreticular endothelial function and causing hepatic failure in the children. So this picture which is showing a normal liver. So normal liver which consisting of an hepatocytes, and this is a microvilli on the, can see microvilli, and this is the endothelial lining, and this is a hepatic stellate cells. When there is a liver injury, there will be an activation of the Kupffer cells, and there is a loss of hepatocyte microvilli. So there is no microvilli as such, and there is an extracellular matrix protein which is increased. There is an increased extracellular matrix protein. So what are the causes for acute liver failure? So the viral infections, herpes simplex virus infection, it is more common in the neonates. Infections acquired during perinatal period. So herpes simplex virus induced acute liver failure carries high mortality, and it is rarely accompanied by some of the skin lesions in the newborn period. So it should be considered in all the sick babies with coagulopathy and the raised transaminase levels. Usually this neonates presented with poor feeding, lethargy, coagulopathy within 2 weeks after the birth. So the drug of choice should be acyclovir, when this should be started in all the neonates with the liver failure, as herpes virus infection is a predominant viral cause. Next is commonest is hepatitis A, B, C, D, E, which may also present as acute liver failure. Hepatitis C is rare in children. So the one of the most important and now which is occurring are the dengue cases, which is causing acute liver failure in children. One of the study done in Thailand shows 40 cases study which was done where there was 66% of mortality. So which is more. So other viruses like cytomegalovirus, herpes simplex virus, Epstein-Barr virus, influenza type A, adenovirus, parvovirus, and echovirus. So these are some of the viral infections. So non-viral causes, which is rare, the children presenting with severe sepsis resulting in the hepatic coagulopathy and hepatic failure, and later a liver transplantation should be done. Next is the bacterial infections by Salmonella, Shigella, E. coli, miliary tuberculosis, leptospirosis, and Plasmodium falciparum infections. So coming to the metabolic diseases, most common metabolic diseases that may present it in as a neonatal acute liver failure are Wilson's disease, galactosemia, hereditary fructose intolerance, tyrosinemia, neonatal hemochromatosis, Niemann-Pick's disease, type C. Coming to ischemic injuries due to hypovolemia or hypotension, congestive cardiac failure. So coming to the drugs, the important drugs. The dose-dependent drugs are acetaminophen and halothane. Idiosyncratic reactions mainly occurring with combinations with isoniazids, NSAIDs, phenytoin, sodium valproate, carbamazepine are anticonvulsant drugs. Antibiotics, penicillin, erythromycin, tetracycline, sulfonamides, quinolones, allopurinol, and propyl thiouracil. Coming to next one is antiretrovirals. So drug combinations which causes liver injuries are isoniazid, rifampicin, trimethoprim, sulfamethoxazole, amoxiclavulinic acid. So coming to the pathology of acute liver hepatic failure. So whenever you do a liver biopsy, which shows there is a pan-acinar hemorrhagic necrosis with a minimal inflammation. So this is a picture which is a histopathological report which is showing a hemorrhagic necrosis. So shows a patchy or a confluent massive necrosis of the hepatocytes, multilobular or the bridging necrosis associated with collapse of a reticular framework of the liver, little or no regeneration of hepatocytes. Zonal pattern of necrosis may be observed in the centrilobular damage. Microvascular fatty infiltrates of the hepatocytes can be seen, evidence of severe hepatocyte dysfunction rather than cell necrosis, which is occasionally a predominant histological findings. So coming to the pathogenesis. So the different stages of the liver failure. So in this picture which is showing, so this is an healthy liver, okay. So whenever there is an insult to the liver, this resulting in the inflammation of the liver, this causes increased liver size due to fatty deposits. So next stage will be fibrosis stage, formation of a scar tissue within the liver. So the liver is the scarring tissues can be seen here. So next stage will be cirrhosis, where the scar tissue replaces the healthy tissue in the liver. Sorry. So next one will be a formation of a liver cancer, that is the malignant cells can be protruded, and following the stage will be end stage liver disease, where the liver function entirely ceases. So whenever there is an insult like hepatitis or something else, other infections, this resulting in the direct cytopathic injuries or an immune mediated injury, this resulting in necrosis in the centrilobular areas, which resulting in diffuse Kupffer cell hyperplasia and parenchymal collapse, resulting in fulminant hepatic failure. So various factors which is contributing for the pathogenesis of the liver failure, which includes impaired hepatocyte regeneration, altered parenchymal perfusion, endotoxemia, decreased hepatic reticuloendothelial function. So I'll be discussing about two components which is important in pediatric age group, that is acetaminophen toxicity and Wilson's disease in briefly. So one of the drugs which is causing acute liver injuries are the acetaminophen, that is a paracetamol. So it is the most important drug of a dose-dependent toxicity. So acute toxic dose will be more than 200 milligram per kg within a 24-hour period in less than 12 years of age. See, the normal dose of paracetamol will be 15 mg per kg per day in divided doses to be given in the children. If the frequency is more and the dose is more, this can result in hepatic injury, that is more than 200 milligram per kg within a 24-hour period. Okay, so that should be noted. So in children, it should be cautiously used. So patients with acetaminophen induced acute liver injury have a high rate of spontaneous recovery than do patients with a viral hepatitis. So what are the clinical evidence of toxicity? So it is classified into 4 stages. So whenever the child comes to the casualty or to OPD, you need to assess at what is the duration of time the child has consumed. So phase 1 will be less than 24 hours, where the child will be presenting with nausea, vomiting. We can discuss this slide. Okay, so less than 24 hours, they usually present with anorexia, nausea, vomiting, and diaphoresis with the normal test report. Coming to stage 2 will be 24 to 72 hours of life. The improved clinically abnormal laboratory test. So this is a clinical findings you need to understand where the child will be normal, but there will be abnormal laboratory test. So you need to, there'll be increased serum transaminases, bilirubin, prothrombin time will be elevated. And coming to stage 3, this is a hepatic stage. The time since ingestion will be 72 to 96 hours. So signs of hepatotoxicity will be elevated serum transaminase levels will be more than 10,000 international unit per liter. They will be prolonged the prothrombin time and INR. So child will be presenting with hypoglycemia, lactic acidosis. The child will be presenting with the acidotic breathing. So total bilirubin levels will be more than 70 micromole per liter, mainly indirect hyperbilirubinemia. So death mainly due to multi-organ failure. Whenever the child in this stage is not treated properly at the stage 3 level, so the child will collapse immediately. And coming to stage 4, that is a recovery stage. So 4 days to 2 weeks, patient who survives stage 3, transient renal failure after 5 to 7 days. And there will be a complete hepatic recovery if it is treated properly with N-acetylcysteine, and the recovery for complete recovery of the liver will take about 3 to 6 months. So this is an important component for acetaminophen toxicity. So coming to Wilson's disease, so it is an autosomal recessive disorder. The condition is mainly due to mutation in the Wilson's disease protein ATP7B gene, so which may present as acute liver failure in older child. It may be due to Wilson's disease, may be suspected in any patients with Coombs negative hemolytic anemia. So this is one of the important thing. One is mutation in the gene in the older children, and Coombs negative hemolytic anemia. You need to suspect Wilson's disease. So what are the manifestations of the Wilson's disease? Mainly in the liver, there will be hepatomegaly, jaundice, acute hepatitis features, fulminant hepatic failure, portal hypertension and bleeding, that is due to bleeding varices, and cirrhosis is the final stage. And coming to the involvement of the bone, this resulting in arthritis or rickets. In the blood component, hemolysis will be there. In the central nervous system, there is deterioration in the school performance of the child, behavioral changes, handwriting deteriorates, resting and intentional tremors may be present, dystonia, dysarthria, excessive salivation and mask-like phases. So this is at the final stage which can be seen in the eye, that is Flesch's ring. And cardiac is cardiac myopathy, renal is proximal renal tubular dysfunction. So these are the clinical findings which can be seen in the Wilson's disease. So how to diagnose a case of hepatic failure? So hepatic failure can be a presenting feature of liver disease, or it can complicate previously known liver diseases, that is acute on chronic liver failure. History of developmental delay or a neuromuscular dysfunction which can indicate underlying mitochondrial or the beta oxidational defect. Child with fulminant hepatic failure has usually been previously healthy and most often has no risk factors for the liver disease such as exposure to toxins or the blood products. So what are the early clinical manifestations which are non-specific and are characterized by lethargy, anorexia, malaise, nausea, vomiting? Progressive jaundice, fetor hepaticus, continuous fever, abdominal pain are common. Rapid decrease in the liver size without any clinical improvement is a very dangerous sign. And hemorrhagic diastasis and ascites can develop in these cases. So patient should be closely observed for hepatic encephalopathy, which is initially characterized by minor disturbances of consciousness or a motor function. Irritability, poor feeding and change in sleep rhythm can be seen in the infants. Asterixis is demonstrated in the older children. So how to take a history in these children? So what is the duration of illness? You need to ask what is the onset of jaundice along with any pallor or any other features of hepatic failure like persistent vomiting, abdominal pain, and any features of encephalopathy, that is lethargy, irritability, not taking feeds adequately. And for the risk factors for hepatitis, example like street food or any sanitational defect, and any blood transfusion in the prior or any surgery like gallbladder surgeries which can be taken, or any hepatic surgeries, and drugs and immunizational history. Family history and consanguinity should be noted. history of any bleeding episode prior or at present, systemic inquiry of involvement of any other systems or any prior past history should be asked properly. Features of any hepatic encephalopathy. So what are the stages of hepatic encephalopathy? So there are 4 stages. So it is classified into you need to divide into symptoms, signs and EEG pattern. So what are the symptoms in the stage 1? So the child usually presents with periods of lethargy. So the child will be lethargic, later the child will be little active. And there is a euphoria, reversal of day-night sleeping and child is alert. What are the signs? Trouble drawing figures, performing mental tasks. So that is EEG, that is electroencephalogram, shows normal feature. Coming to stage 2, the symptoms will be drowsiness, inappropriate behavior, agitation, wide mood swings, disorientation. The signs will be asterixis, fetor hepaticus and incontinence. Electroencephalogram shows generalized slowing and Q waves will be present. So in the stage 3, the symptoms will be stupor but arousable, child will be confused, incoherent speech. So the child will be speaking irrelevantly. Coming to the signs, asterixis, hyperreflexia, extensor reflexes, and there is rigidity. So encephalogram shows markedly abnormal triphasic waves. So coming to the stage 4, the symptoms will be child will be comatose, 4A will be responding to the noxious stimuli, 4B will be there is no response to the stimuli. Coming to the signs, there is areflexia, no asterixis, child will be flaccid. So encephalogram shows markedly abnormal bilateral slowing, D waves, electrocortical silence will be seen. So this is an important staging. This is taken from Nelson and which is an important component for assessing the child. So what are the aggravating factors for hepatic encephalopathy? That is gastrointestinal bleeding, hypovolemia, hypokalemia, hypoglycemia, sedatives, uremia, sepsis, high protein diet, constipation and paracentesis. So these are the aggravating factors for hepatic encephalopathy. So what are the physical examination when you assess the child? So mainly you need to look for jaundice and anemia. So pallor and jaundice is an important clinical findings. Coming to the vital signs, there will be hypotension, tachycardia, tachypnea. The mental status should be assessed. How is the child's orientation, memory, everything, higher mental function should be assessed. And on examination, hepatomegaly should be present and splenomegaly, which is associated finding, stigmata of chronic liver diseases and ascites will be present. Features of raised intracranial pressure like excessive crying and irritability and bulging anterior frontal, everything can be seen in these children's. Nervous system examination, which is very important to be done in the cases of hepatic injuries. So these are the picture which is showing the systemic manifestations of acute liver failure. So the most important which can causes will be in the brain, resulting in hepatic encephalopathy, brain edema in the increased intracranial tension. And in the blood, there will be neutrophil dysfunction and systemic inflammatory response which can cause. In the muscles, muscle catabolism can occur. Acute renal injury can occur and adrenal insufficiency. Whereas in abdomen, there will be portal hypertension, pancreatitis, because this is due to bleeding manifestations can be seen. And in the intestine, ileus and cardiovascular system, there will be cardiomyopathies and cardiac dysfunction. Whereas in the lungs, there will be respiratory distress syndrome. So these are the systemic manifestations of the acute liver failure. So coming to the investigations for these children. What are the investigations? Most important investigation shows the complete blood count should be done, where the total count will be elevated because of sepsis and thrombocytopenia. Liver function test will be revealing serum bilirubin level will be elevated and serum aminotransferase and alanine transferase levels will be elevated. Alkaline phosphatase may be normal or raised. And coagulopathies like PT and INR levels is varying according to the condition of the child. So this is an important investigation should be done to assess the severity of coagulopathy. Blood grouping and cross matching and blood urine culture should be sent. So what are the biochemical tests? Serum electrolytes, where the child will be presenting with hypokalemia and hyponatremia features. Serum glucose levels will be, child will be developing hypoglycemia. Serum creatinine level initially may be elevated and urea also will be elevated. Serum ammonia levels are elevated. It is massively elevated, then you suspect hepatic encephalopathy. Serum calcium levels, phosphate and magnesium levels should be assessed. And serum lactate level, which is an important investigation which should be seen as a predictor for acetaminophen induced acute liver injury. So where the levels at 4 hours after the paracetamol toxicity, if it is more than 3.5 or at 12 hours more than 3, are the early predictors for the outcome of liver failure due to paracetamol toxicity. And most important is acid-base analysis, that is blood gas analysis should be done. So coming to detecting the cause for the condition, that is the serological markers should be assessed. That is anti-hepatitis A virus, IgM levels should be done. Hepatitis B antigen levels, anti-hepatitis B immunoglobulin M should be assessed. And anti-hepatitis E virus IgM levels should be assessed. Screening for other viruses like herpes simplex virus, cytomegalovirus infection, all screening should be done to rule out the cause for this hepatic failure. So coming to the immunological test, so this is at the later level where the diagnosis is not ascertained. So serum immunoglobulins, ANA levels, anti-Smith and ANA levels and anti-LKM1 antibody levels should be assessed. And next, when there is a paracetamol toxicity, serum acetaminophen level should be assessed. Ultrasound for the hepatobiliary system, chest X-ray for any comorbidities associated with the lungs should be assessed, and screening for metabolic diseases. Electroencephalogram should be done. Liver biopsy is the last resort. In autoimmune metabolic causes of the liver failure should be done. So coming for the Wilson's disease screening, eye examination shows KF ring and cataract. Serum copper level should be ascertained, should be to be assessed. Serum ceruloplasmin and 24-hour urinary copper. So these are the 3 important levels should be assessed in the Wilson's disease. So coming to management of acute liver failure. So there will be medical management and surgical management. So medical will be mainly to maintain the physiological functions of the liver. That is supportive care or a specific treatment should be given. Surgical management is extracorporeal system and liver transplantation. So what is the supportive care for the children? Usually these children should be in a quiet environment. So the child should be like isolated to certain areas where there is no noise. Because if there is any noise, the child will get agitated and there will be increased in the intracranial pressure, which resulting in very bad prognosis. And usually these children should be seen in the ICU, should be monitored in ICU. Avoid sedation and stimulation. Fluid restriction, which is the most important component. That is, you need to restrict about 60 to 80% of the daily requirement should be given, not 100% of the fluid. Choice of fluid is 0.2 to 5% of sodium chloride. That is 1/4 of the normal saline. So that is 1/4 of the normal saline in 10% of dextrose. This is a choice of fluid should be given for acute liver failure. Which is presenting with hepatic encephalopathy also. The fluid choice is 1/4 of the normal saline. Prevention of hypoglycemia. Normally we need to maintain more than 45 to 50 milligram per deciliter or more than 4 millimole per liter. So medications that affects the levels of consciousness should be avoided. If sedation is required, because if the child is very agitated or irritated, then the drug which can be given is propofol, that is 1 to 2 milligram per kg only can be given. So no other sedatives should be given. So why sedatives are not given? Because if sedations are given, then you cannot assess the status, that is Glasgow GCS scaling cannot be done and stages of hepatic encephalopathy will be missed out. So IV H2 blocker or PPI should be given. Antibiotics like cefuroxime, amoxicillin and fluconazole according to King's College protocol. These are the antibiotics which can be given. or according to Indian protocol, it is cefotaxime plus fluoxetine. So anemia should be corrected to ensure maximum of oxygen supply to the tissues by giving blood transfusion. Lactulose to eliminate ammonia levels in hepatic encephalopathy, and close monitoring. The child should be monitored closely for oxygen saturation. Whenever there is a drop in saturation less than 90%, then you need to anticipate some of the causes. So clinical status, the pulse and BP should be monitored hourly, and liver size every 4th hourly should be monitored. Strict input-output chart, avoid fluid overload. Central venous line should be inserted. Foleys and arterial line should be inserted, and to be monitoring the BP, like that is a mean arterial BP, mean arterial pressure, that is blood pressure more than 60 mm of Hg should be maintained. So frequent evaluation of blood gas analysis and the neurological status by GCS analysis is very important in these children. 12-hourly electrolyte coagulation profile, ABG, blood sugar level should be done every 12th hourly, and GCS scaling should be done every hourly. So daily measurement of liver span and what medication the child is receiving is an important topic which should be written in every note. And LFT, RFT, serum calcium, serum phosphorus level should be done twice weekly. Raised intracranial pressure should be monitored if suspecting, then emergency CT scan and give IV mannitol or 3% NaCl when you're suspecting raised intracranial pressure. Any suspicion of sepsis, then appropriate antibiotics. Fungal infection if you're suspecting antifungals, and management of AKI. So most important is nutrition is an important factor in the acute liver failure. So what are the commonest complications of acute liver failure? Encephalopathy, cerebral edema, raised ICP, infection, coagulopathy, hypoglycemia, dyselectrolytemia, acid-base disturbances, and finally it is a multi-organ failure. So coming to management of the complications, the important complications I'll be dealing. So one will be how to treat encephalopathy, mainly by low protein by mouth, lactulose about 10 to 50 ml every 2nd to 4th hourly. Acid enema should be given, that is lactulose enema, vinegar can be given every 6th hourly. Treat the sepsis, bleeds and electrolyte imbalance. Avoid sedation, and flumazenil, which is a short-lived drug which can be given. For cerebral edema, the child should be at a 20 to 30 degree elevation, and IV mannitol or hypertonic saline, 3% NaCl can be given. Hyperventilation may help to decrease ICP. Hypothermia decreases ICP, and avoid hyperthermia. So you need to maintain hypothermia, avoid hyperthermia. So how to treat bleeding manifestation? Initially you need to give injection vitamin K at 1 mg per can be given. And a fresh frozen plasma, platelet transfusion should be given if the platelet count is less than 10,000 per cubic millimeter, or a platelet count is less than 50,000 with any features of bleeding manifestation. So fresh whole blood transfusion if necessary. Recombinant factor 7 to be given. So when there is a changes in the acid base, then what are the treatment you can give? So volume expansion by giving adequate fluid, normal saline can be given. Dopamine infusion, sodium bicarbonate when there is a bicarbonate levels are less. Mechanical ventilation for respiratory acidosis, and for treating septicemia. So most commonest causes is for gram-positive septicemias, that is in 2/3 of cases, and gram-negative will be 1/3 of cases. So septic workup will be blood culture, sputum culture, and urine culture can be done. So cefuroxime, amoxicillin, fluconazole can be given. For fungal infection, IV is used. So what are the renal complications, how to manage this? Renal failure may occur in 50% of the patient with acute liver failure due to hepatorenal syndrome. Acute tubular necrosis due to sepsis, endotoxemia, bleeding, hypotension, directly by nephrotoxic drugs. So treatment mainly by dopamine infusion, correct fluid overload, correcting acidosis by sodium bicarbonate, and hyperkalemia, avoid nephrotoxic drugs. If it is not resolved, then you need to go for dialysis. So what is the specific treatment in this children's? So when you're suspecting any infectious causes like malaria, typhoid, leptospirosis, or herpes infection, or any other viral infection, to respective antibiotics or antiviral can be given. So if you're suspecting any drug or toxin toxicity, so then you need to remove the toxin metabolites for the liver to function normally. If it is acetoaminophene toxicity, then N-acetylcysteine is an antidote. When you're suspecting any metabolic diseases like Wilson's disease, galactosemia, fatty acid oxidation, then liver transplant is the last resort. Remove the dietary lactulose, IV glucose, and avoid fasting in these metabolic conditions. And when they are suspecting any immune dysregulation like autoimmune hepatitis or neonatal hemochromatosis, then corticosteroid antioxidant cocktail, that is combination of multi-drugs, should be given to these children. What is N-acetylcysteine? It is a derivative of cysteine, antioxidant reactive of oxygen and nitrous species. It replenishes depleted glutathione. It improves the oxygen carrying capacity, and it has an anti-inflammatory effect. So next resort is the extracorporeal liver assisted device. So which is seen at it's a rare treatment which can be given, and it is very complicated treatment. This treatment is given for the children with the final stages of the liver failure. So it may be artificial or the bioartificial. It is to bridge the liver transplantation for the regeneration of a native liver, to remove the toxin substances or to improve the survival and hepatic encephalopathy. So this picture is very blurred, I think. So where the patients, the liver support can be done through this artificial, like normally we'll do for dialysis, like peritoneal dialysis, and the normal renal dialysis can be done. No? So like this, it's a liver dialysis which can be done through this chamber. So coming to the liver transplantation, so which is a 5-marker question for you people. Liver transplantation is a definitive treatment which has transformed the management of acute liver failure. Several prognostic scoring systems have been advised to predict the mortality and to identify those requiring early liver transplantation, which includes King's College Hospital criteria, pediatric end-stage liver disease score, FHS2 scoring, and Lynch's criteria. So now we'll be using King's College criteria for liver transplantation. When there is a drug acetaminophen cases, then these are the components which should fit for the liver transplantation. That is arterial pH less than 7.3, or arterial lactate more than 3.5 at 4 hours, or arterial lactate more than 3 at 12 hours, INR more than 6.5, creatinine more than 3.5, and stage 3 or 4 encephalopathy. So these all criteria should fit in acetaminophen cases for the liver transplantation. Whereas non-acetaminophen cases, that is other than drug toxicity, if the INR level is more than 6.5 or any of the following criteria: age less than 10 years or more than 40 years of age, duration of jaundice more than 7 days, total bilirubin more than 17.5 milligram per deciliter, INR more than 3.5, etiology idiosyncratic drug, allothane, idiopathic, non-A, non-B hepatitis. So you need to, any of the 3 following criteria should be there along with INR more than 6.5 for the liver transplantation to occur. So survival increased from 20 to 60 to 80% in various studies, which has changed the outlook and natural courses. So what are the contraindications for the liver transplantation? When there is an active, uncontrollable and untreatable sepsis, severe cardiopulmonary disease, multi-organ failure, extrahepatic malignancies, mitochondrial disease, active substance abuse, and hepatic encephalopathy, grade 4 encephalopathy, that is grade 4 encephalopathy with a severe neurological impairment. So these all are the contraindications for not applicable for liver transplantation. So what is the prognosis? Overall mortality with a supportive care exceeds 70%. With intensive medical support, survival rate is 50 to 60% in the acetaminophen overdose and fulminant hepatic hepatitis A virus or hepatitis B viral infections. In idiopathic form of acute liver failure or acute onset of Wilson's disease, mortality rate is about 80 to 90%. The prothrombin time is the best indicator for survival. 73% of children with an INR less than 4 surviving versus only 4 of 24 with INR more than 4. This is how the widely accepted criteria. So mainly indicator is INR and PT should be done in children with hepatic encephalopathy or any liver diseases. So where the poor prognosis is mainly seen in the children less than 1 year of age and stage 4 hepatic encephalopathy when INR is more than 4. Persistently INR more than 4 is a bad prognosis. Need for dialysis before the liver transplantation. Elevated serum bilirubin and prothrombin time which cannot be corrected. High arterial ammonia levels. High WBC count. Low alanine aminotransferases. So these are the poor prognostic signs which can be assessed. So these are the references. You can go through this. Mainly I've taken from Nelson textbook and OP Guy and Management of Acute Liver Failure IAP textbook of Pediatrics. Okay. Any questions? See, this is one of the important topic. Either they may ask as a 5-marker or a 3-marker question, mainly paracetamol toxicity management or Wilson's disease as a 5-marker question with along with causes, etiology, clinical findings and management. And liver transplantation as a 5-marker question or long question can be asked as a hepatic failure, etiology, causes, management. So these are the like many questions can be asked and N-acetylcysteine also can be asked. So any questions are there? So the class strength is 152. So any questions? So if there's no questions, I'll be ending the class. Stay safe and stay healthy. Okay. So I'll be taking attendance now. Okay. So there are totally 152 students. Thank you.